I am Regina Nalon, a clinical nurse researcher at the Nebraska Medical Center. I have served on the hospital's fall reduction team for 5 years and continue to assist staff with implementing best practices in fall risk reduction.
And I'm Deborah Conley, a gerontological clinical nurse specialist. I champion the fall risk reduction team at Nebraska Methodist Hospital and coordinate our Nurses Improving Care for Health System Elders and the Age-Wise Gero-Palliative Care Nurse Residency programs.
This learning module, Fall Risk Reduction, Best Practices for Nursing Staff in the Acute Care Setting, is one component of the Capture Falls Toolkit. The purpose of the Capture Falls project is to decrease the risk of inpatient falls in small rural hospitals. This project is supported by grant number R18HS021429 from the Agency for Healthcare Research and Quality. The content is solely the responsibility of the authors and does not necessarily represent the official views of the Agency for Healthcare Research and Quality. A research study was done by the Capture Falls team with critical access hospitals across Nebraska in 2011, in which the study team was examining the hospital's current state with fall risk reduction activities. This webinar will focus on 4 learning objectives. We will review baseline data from 2011 hospital survey specific to fall risk reduction. We will discuss best practices in fall risk reduction and fall prevention interventions. We will talk about methods to evaluate fall risk reduction structures and processes, and we'll summarize by reviewing main points of the presentation content. Part 1 will provide the introduction and background of this webinar. An introduction to best practices in fall risk reduction will now be presented. Much of the content in this webinar is derived from what we know in the published literature. References for this presentation are available on slides 50 through 53 of the handout that accompanies this webinar. The webinar content handout is available as a PDF document on the Capture Falls website. The last slide of this webinar provides you with the website address. The literature reveals several key points about fall risk reduction. First, fall risk has been reduced in studies where interprofessional team members were actively engaged in fall risk reduction efforts. And secondly, an interprofessional team versus a nursing strategy only, and use of benchmarks are associated with sustained improvement. What is evidence-based practice? Well, evidence-based practice has 3 major integrated components that can be conceptualized as a puzzle with the pieces fitting together. Evidence-based practice is the integration of best research evidence with clinical expertise and patient values. When we think about assessing quality of care, we find it helpful to use Donna Bedian's framework, in which quality is a component of healthcare that occurs within the context of patient care. There are 3 main components of the framework: structure, process, and outcomes. Structure includes the infrastructure that's in place that supports care provision, human resources, equipment, the environment, policies and procedures. Process includes the actions taken to reduce fall risk, staff following policies, procedures for fall risk reduction program, prevention interventions, or having staff and patient education is also considered a process. Outcome is the unit or hospital fall rate per 1,000 patient days, or the injury fall rate per 1,000 patient days. The Capture Falls research team used this framework as we surveyed Nebraska hospitals in 2011. We examined the extent to which hospitals had in place structures and processes related to fall risk reduction, and we looked at their fall outcomes within this context. 70 hospitals in Nebraska responded to our survey from the 83 general community hospitals in the state. The sample included 56 of Nebraska's 65 critical access hospitals, those hospitals with 25 or fewer beds, and 14 of the state's 18 non-critical access hospitals. We were very pleased with the overall response rate of 84% of the state's general community hospitals that participated in our survey. We asked hospitals who was accountable for implementing their hospital's fall risk reduction program. The pie chart on the left of this slide indicates that 14% of the non-critical access hospitals had an individual who was accountable, and 86% had a team accountable for implementing their hospital's fall risk reduction program. The pie chart on the right side of this slide shows that out of the 56 critical access hospitals, those with 25 or fewer beds, 27% had no one who was accountable, 25% had an individual who was accountable, and 48% had a team that was accountable for implementing their hospital's fall risk reduction program. This tells us overwhelmingly that the critical access hospitals looked very different from the non-critical access hospitals in that there was much less structure around the accountability for implementing the fall risk reduction program in these hospitals. We asked the hospitals about processes in place that were aimed at fall risk reduction. According to the Institute for Clinical Systems Improvement, there are universal fall prevention interventions that are used for all patients, and there are also targeted interventions that should be used for specific subsets of patients identified as at risk for falling. This slide displays the percentage of hospitals using each of the universal interventions listed, categorized by whether there was no one, or there was an individual, or there was a team that was accountable for implementing the fall risk reduction program. We see from this data that regardless of accountability structure, nearly all hospitals implemented the universal interventions of placing the call light within patient's reach and documenting fall risk in the patient's medical record. However, hospitals were less likely to have implemented hourly rounding and patient or family education for every fall risk patient. We also see that regardless of accountability structure, hospitals were also less likely to have implemented colored wristband and signage, bed or chair alarms, or use of increased lighting for all at-risk patients. As far as targeted interventions by the hospital's accountability structure, what we found was that hospitals with a team in place were more likely to implement medication reviews, occupational therapy evaluations, and use of handoff tools to communicate a patient's fall risk than hospitals that had no one or an individual accountable for implementing the fall risk reduction program. Another process we asked about in our survey in 2011 was the extent that staff discussed fall risk as part of daily patient care. We asked if patient care staff from multiple disciplines discussed the patient's fall risk in the context of daily care. Of the 15 hospitals with no one accountable for fall risk reduction, only 14% discussed fall risk. Of the 16 hospitals with one individual accountable for fall risk reduction, 25% discussed fall risk. And of the 39 hospitals with a team accountable for fall risk reduction, 50% discussed fall risk. We also asked hospitals about the role that communication plays in their fall risk reduction efforts. Specifically, we asked if they communicated fall risk status to patients and families, and whether staff communicated with other staff members across shifts and across units and/or departments. What the data revealed was that hospitals with an individual or with teams tended to communicate fall risk more frequently to patients, families, and across units and departments. Of the 15 hospitals with no one accountable for fall risk reduction, 27% of them indicated that staff frequently or always receive information about actions taken to improve care as a result of falls. Of the 16 hospitals with one individual accountable for fall risk reduction, just over half, 53%, indicated that staff frequently or always receive information about actions taken to improve care as a result of falls. Of the 39 hospitals with a team accountable for fall risk reduction, 63% indicated that staff frequently or always receive information about actions taken to improve care as a result of falls. According to the Institute for Clinical Systems Improvement, all hospital staff, clinical and non-clinical, need to know the hospital's policies and procedures for fall prevention. Education needs to be ongoing and include fall prevention interventions, universal and targeted, post-fall protocols, what to do after a patient falls, and environmental indicators that can pose hazards. As a reminder, references for this presentation are available in the handout that accompanies this webinar. The webinar content handout is available as a PDF document on the Capture Falls website. The last slide of this webinar provides you with that website address. In Part 1, our goal has been to describe the structures, processes, and outcomes of fall risk reduction across Nebraska hospitals. Our survey told us that team structure and not hospital size significantly predicts rates of patient falls with injury. By highlighting where structures and processes are not consistent with the evidence, we provide a strategy for improvement that includes an interprofessional team, consistent use of a valid risk assessment tool, consistency with implementation of universal and targeted interventions, communication to all team members across shifts and departments, and communicating fall risk status and interventions in place to patients and their families. It's important for hospitals to learn from their data and benchmark their fall outcomes with other hospitals. Based on the data and on examining structures and processes, policies and procedures can be modified to make them consistent with what the evidence tells us is best practice. I'll now turn the webinar content to Deb, who will describe best practices for fall risk reduction in the hospitalized patient.
In this next section, part 2 of this webinar, I will be presenting about reducing fall risk in the hospitalized patient. It involves all staff members, the patient, and family. There are 2 categories of interventions or strategies to implement in your fall risk reduction program: universal interventions and targeted interventions. The first one we will review is universal interventions. Those interventions that are implemented for all patients and are not dependent upon the patient's level of risk or fall risk assessment score. Universal interventions can be divided into 2 categories to make them easier to remember: environmental and mobility. The environment plays a huge role in keeping patients safe. Ways staff can improve the environment of care are to communicate with staff and to the patient and family any hospital-related factors that may potentially cause a fall, like dizziness, impaired vision, or unsteady gait. Specific information about that patient. Familiarize the patient to the environment and ask the patient to teach back or provide a return demonstration on how to use the call light and when they would use it. Reducing hazards such as keeping the room clutter-free, room floor clean and dry, keeping the call light and personal possessions all within reach. Encourage the use of handrails in the bathroom, room, and hallway. Always have patients wear non-slip gripper socks or well-fitting footwear when they are out of bed, and provide a nightlight or supplemental lighting in the room. Assess the need for one-to-one monitoring and arrange as needed. Asking family members who are familiar with the patient to assist is helpful, especially if the patient is confused. Minimize or avoid the use of both chemical and/or physical restraints. Keep bed in the lowest position with wheels locked when patient is lying in bed, and reevaluate bed height when patient needs to stand up. Lock wheelchairs when the patient is in the chair, as well as when the patient's not sitting in it. You never know when someone's going to sit in a chair, and we don't want it rolling. Keep the top side rails up to encourage bed mobility and movement. And highlighted on the slide is hourly rounding, or going into the patient's room with intention or for a purpose. This is when you are assessing what has been coined the 4 Ps. Is the patient experiencing pain? Is the patient positioned comfortably? Does the patient have all of their belongings within their reach or proximity? Does the patient have any personal needs, need for toileting? After the 4 Ps have been addressed, staff can ask the question, is there anything else I can do for you right now before I leave your room? Safe mobility is supported by using gait or safety belts, easily accessible for staff to use in the room with patients who do not walk independently. Use proper technique to transfer patient, communicate this from shift to shift and at all handoffs. Monitor gait, balance, and fatigue level with mobility. Instruct patients to rise slowly and sit on the edge of the bed or chair if necessary. And the bed is not your friend can be the hospital motto to encourage ambulation in the hallway and up for all meals if the patient is not on physician-ordered bed rest. Once universal interventions are in place for all patients, staff can target specific interventions based on the patient's level of risk for a fall and risk for injury. In this section, we will cover specific targeted interventions. When thinking about targeted interventions, ask yourself, what are the unique characteristics of this patient that place him or her at risk for falling? What interventions need to be in place to this patient's fall risk factors in addition to the universal interventions already in place? For example, what circumstances is this patient experiencing, like dizziness or unstable gait, or they forget their own limitations and get up without calling for help, that need to be addressed via targeted interventions? Once a patient has been identified at a certain level of risk using your fall risk assessment tool, this needs to be communicated to the patient, family, and all staff. Visual reminders or communication can be in the form of signage on the door in the room, colored armband, non-skid socks. Since patients travel within a hospital to x-ray, lab, therapy, the signage you use must be mobile and visible to the other departments, identifying the patient's level of fall risk. Verbal communication needs to occur with patients and families. Use the teach-back method as ask patients to demonstrate the use of the call light or other information you want to make sure they know. It's important to communicate fall risk among staff and to document it in the chart for others to see. It's also important to communicate across departments and units and across facilities. Engaging patients and families in promoting a culture of safety and seeking their input on fall risk reduction strategies is key. Ways to do this include sharing with them the patient's fall risk at admission, when risk status changes, and at discharge. Review the hospital's fall prevention program, what the signage or the armband, sock, and the socks mean, what their role is in keeping the patient safe. Follow staff instructions and why. For example, if the patient or family does not like, for example, a bed exit alarm, share with them it is your hospital fall policy to turn this on for patients who tend to get up on their own. The bed alarm alerts, summons staff quickly to the room to assist the patient with ambulation or other needs. We also need to communicate how to contact staff when necessary. Ask the patient to demonstrate when and how to use the call light. Document in the medical record evidence of patient education and patient-family understanding of risk and prevention measures using teach-back. Just like universal interventions, which focused on the environment, we also have targeted interventions focusing on the environment. What type of pharmacological factors for this patient contributes to their risk of falling? Consider a pharmacy consult for medication review. That's a targeted intervention. Identify cognitive or physical deficits that contribute to a patient's fall risk. If a patient has impaired vision in the right eye, arranging personal items on the left side of the bed is a targeted intervention to help compensate for the vision loss. Calm an agitated patient with unhurried, soothing voice tone, music, familiar face, and ask family members to stay with them if possible. Provide a calm environment where interruptions are limited and time is provided for the patient to rest. Maintain consistency in procedures, routines, and staff allocation. Identify possible triggers for agitated or impulsive behavior. Examples would be medications, the time of day, possibly the patient having an infection, loud noise. We need to minimize these triggers when possible. Provide patients who are dependent with an adapted means of summoning help. Place bright colors on a call light to make it easier to see. Connect it to their gown or the upper side rail. Consider a physical therapy or occupational therapy or a behavioral therapy consult for behavioral management. Maximize orientation, awareness, and function. Determine whether mobility aids are needed and are used appropriately and correctly. Another category for targeted intervention is bed and toileting. These patients need supervision and/or assistance with personal needs and mobility. Best practices to implement include use bed and chair exit alarms at all times, making sure they are functioning each time the staff member is in the room. Supervise transfers and ambulation. Take the patient to the toilet on a regular schedule, not asking the patient if they need to toilet, but saying, "I'm here to assist you to the toilet." Toilet patient before administering sedating medications. Use raised toilet seat as needed and seek an occupational therapy consult with questions. A staff member should remain with the patient when in the bathroom or if the patient uses a bedside commode. It's been said that safety trumps privacy. Have this conversation with your patient so they know that why you're attending to them while in the bathroom, and provide as much privacy as possible. The next category for targeted interventions is mobility. Keeping patients mobile and out of bed prevents lower extremity weakness, which we know contributes to falls. Use personal sensory and assistive devices such as hearing aids, glasses, walker, or a cane. Again, consider a PT/OT consult for mobility safety. Use wheelchair and bedside chair of proper height. Keep wheelchair leg rests off the floor and out of the way. Lock wheels of wheelchair or rolling chairs and the bed. Use lifts for patients who meet lift criteria in your hospital. Additional mobility targeted interventions include the use of hip protectors for patients at high risk for a hip fracture, specifically those with brittle bones or who have osteoporosis. Consider the use of helmets to prevent head injury with patients on anticoagulation medications or who are neurologically impaired. Bilateral safety mats on either side of a regular bed for those 85 years of age and older have been found to reduce the risk of injury in these patients. The clinician's clinical judgment and critical thinking is paramount in fall prevention. Despite a patient's fall risk assessment score, staff may believe that a patient would benefit from targeted fall prevention interventions. Therefore, follow your clinical instinct and implement them. Individualize the patient's care according to the patient's need. Avoid looking only at a risk score, but think about the categories we've talked about. Does the patient have difficulty with mobility or cognitive impairment which prevents them from calling for help? Does the patient need a toileting schedule or assistance with locating the call light? Regina will now talk about best practices evaluating your hospital's fall risk reduction efforts.
A big part of fall risk reduction is knowing whether our efforts are working. Part 3 of our webinar will discuss best practices for evaluating fall risk reduction efforts. One structure and process identified as a best practice in fall risk reduction is the conduct of post-fall huddles. The huddle is an activity conducted by staff who were caring for the patient at the time of the fall. After the patient is assessed and stabilized, a huddle is performed in the patient room and initiated by the charge nurse or designee for the team to discuss factors that may have contributed to the fall. The team might include the registered nurse, the patient care tech or nursing assistant, the patient and any family that might be present, the physician if present, the pharmacist, and physical therapy or occupational therapy if they were part of the patient's care team. As I indicated, the post-fall huddle is one suggested best practice. The huddle allows for immediate learning from the situation as to what happened and what can be done to prevent another fall from occurring. There are several suggested talking points that can be used to direct the conduct of the post-fall huddle. For instance, were there task errors, planned interventions that were not in place as intended? Were there judgment errors? Strategy used to assist with transfers or gait was inappropriate. Were there care coordination errors? The fall risk status was not communicated to all parties. Is there a need to consult with physical therapy about balance or transfers or mobility? Is there a need to consult with pharmacy about medications? These are all prompts for the team to dig deeper into the event after it happened and to be able to identify what processes can be put into place to keep the patient safe from falling again. It is important that the whole unit and other departments can learn from post-fall huddles. So we suggest and encourage that you develop a process where this information gets funneled for wider learning across staff so that they can also learn how to prevent falls. Another process identified as best practice is to conduct audits on the extent to which processes are in place that should be to reduce the patient's risk for falling. Slide 39 displays a fall reduction process and structure audit tool that we've developed for the purposes of illustrating some of the components that you might want to audit to measure the effectiveness of staff following expected policies and procedures related to fall risk reduction. This tool is available on the tool inventory page of the Capture Falls project website. The last slide in this webinar provides you with the website address. An audit focusing on fall prevention structures and processes contains elements you may want to measure on a periodic basis, perhaps monthly, to determine if the interventions that should be in place actually are with your fall risk patients. What you would do in your hospital is assign a staff member, perhaps a member of the fall reduction team, from each unit to audit the fall risk patients on a randomly selected day each month. Depending on the size of the patient care unit, maybe 50% of the at-risk patients will be audited. If it is a small unit, perhaps 100% of the fall risk patients will be audited. The auditor identifies the patients who are at risk of falling per their last recorded fall risk score in the patient's medical record and proceeds with auditing whether the processes are in place that should be per your hospital's policy. Another measure of the effectiveness of fall risk reduction activities in your hospital is the actual number of falls and injury falls that occur. According to the Institute for Clinical Systems Improvement, transparency of fall rates by sharing between hospital units, hospitals, and hospital systems, or public reporting has a positive effect on falls and injury reduction. Staff awareness of fall rates have been shown to help improve fall risk reduction efforts. For the purposes of our project, we use the definition of a fall that is also used by the National Database of Nursing Quality Indicators. A patient fall is a sudden, unintentional descent with or without injury to the patient that results in the patient coming to rest on the floor or on or against another surface, such as a counter, on another person, or on an object, such as a trash can. Injury levels can range from minor, bruising, to major, fracture, or death. Slide 42 displays the method of calculating a fall rate or an injury fall rate. Fall rates can be calculated at the unit level or at the hospital level. To calculate the fall rate per 1,000 patient days, you take the number of falls that occurred over the month or over the year, depending on what time frame you are examining, divided by the number of patient days in that month or time period, multiplied by 1,000. The same calculation is used for determining injury fall rate. You take the number of injury falls that occurred, divided by the number of patient days, multiplied by 1,000. The reason we multiply the value by 1,000 is to provide a common means of comparing fall rates across settings. It's likely easier for you to count the number of falls that occur, as these are recorded through your hospital's incident reporting system. A more challenging task is to accurately measure patient days. Let me now give you some examples of how to calculate patient days. One method of calculating patient days is called the midnight census method. This method is a count of all patients on the unit at one time each day. You then record the number of patients on the unit each day at midnight. At the end of the month, sum the daily midnight census counts. You would then add up each month's patient days over a year to calculate the fall rate across a calendar year. Let's look at a specific example of how to calculate patient days for 1 month using the midnight census method. Let's say that from September 1st to the 10th, there were 4 patients on Unit A at midnight each day. From September 11 to September 30, there were 5 patients on the unit at midnight each day. Day 1 through 10 was 10 days, times 4 patients on the unit each day of those surveys, and that equals 40 patient days. On the next 20 days of the month, there were 5 patients on the unit each day, which comes out to be 100 patient days. 40 patient days plus 100 patient days equals 140 for Unit A. To calculate the unit's fall rate, you would take the number of falls that occurred on Unit A in the month of September and divide that by the number of patient days and multiply the outcome by 1,000. Let's say that Unit A had 2 falls in September. 2 divided by 140, the number of patient days, equals 0.014. Multiplied by 1,000 equals 14.3. Unit A fall rate for September was 14.3 per 1,000 patient days. You would repeat this same process using Unit A injury fall count for September to calculate the unit's injury fall rate per 1,000 patient days. If your hospital has several different units, you would combine all the data for all the units in the hospital to calculate the hospital's total fall rate and injury fall rate per 1,000 patient days. Another method of calculating patient days is the actual hours method. In this method, the actual number of hours a patient spends on the unit based on arrival and departure times within a calendar month is collected. You sum the hours that all patients spend on each unit each month, and you divide the total number of hours by 24 to obtain each unit's patient days. Let's say that patient A was admitted on September 1st at 8:30 in the morning and was discharged on September 7th at 4 p.m. 6 days times 24 hours plus 7.5 hours on September 7th gives this patient's total of hours in the hospital 151.5. Patient B was admitted on September 2nd at 8 p.m. and discharged on September 31st at 10 a.m. 28 days times 24 hours plus 14 hours on the 31st equals 686 hours. 8 additional patients were on the unit in September for a total of 2,340 hours. The total actual hours for September equals 151.5 plus 686 plus 2,340 for a total of 3,177.5. We now have to divide this by 24 to get the number of patient days that these hours add up to across the month. The patient days for the month of September would be 3,177.5 divided by 24 equals 132.39. Using the actual hours method, we now use the same number of falls from the previous example. Unit A had 2 falls in September. 2 divided by 132 patient days multiplied by 1,000 equals 15.1. You would repeat this same process using Unit A injury fall count for September to calculate the unit's injury fall rate per 1,000 patient days. And again, if your hospital has several different units, you would combine all the data for all the units in the hospital to calculate the hospital's total fall rate and injury fall rate per 1,000 patient days. This webinar has provided an overview of best practices in fall risk reduction for nursing staff in the acute care setting. Key points to take away include the importance of communicating the patient's fall risk to other members of the care team, as well as to the patient and his or her family members. It is also critical to educate the patient and family about why they are at risk and what their role is in helping to prevent the patient from falling. This likely will include educating the patient and family about the use of the call light for assistance, educating them about the signage and tools that will be used in the fall prevention efforts during the hospital stay, such as special colored socks or a special colored wristband, or signage such as magnets or other symbols that indicate the patient's fall risk to all who enter the patient's hospital room. Best practices also include ongoing staff education related to the hospital's fall risk reduction policies and procedures. Universal interventions are those that are applied to every patient in the hospital. Nurses and other care providers can determine which targeted interventions are best for any individual patient. It's important to tailor the fall prevention interventions to the patient's needs. Measuring and evaluating the hospital's fall risk reduction structures and processes provides you with data that you can use to make meaningful decisions about the hospital's fall reduction program. Lessons learned from post-fall huddles and from fall audits should be shared with staff across the unit and across the hospital. Fall reduction is a team effort, and anyone having contact with the patient is a stakeholder in the effectiveness of the hospital's fall risk reduction efforts. As indicated earlier, the last several slides of the webinar include references that are available on the handout that accompany this webinar. Please consult the Capture Falls project website for additional resources. Type Capture Falls into an internet search engine or enter the URL or website address found on this last slide.